Yeah, well, I think we have fairly clear standards of practice now for GE junction esophageal adenocarcinomas. I think radiation is still required, combined with chemotherapy, because you want to achieve a negative margin surgical resection. There are troubling data from Great Britain that if you give chemotherapy alone, you have R0 resection rates in the 60s. When you add radiation, it goes up to the 80s and 90s, so that I think radiation is an obligate part of neoadjuvant treatment for the more proximal esophageal and GE junction tumors, and the cross-regimen carboplatin paclitaxel radiation remains a standard. For more distal gastric cancers, we have the positive results from the FLOT4 German trial, which compared FLOT, which is docetaxel plus 5-FU-oxaliplatin, a triplet regimen. That bested ECF and ECX in a randomized trial in GE junction and gastric cancer. You had higher rates of curative resection, higher response, and nearly a 10% improvement in survival for the FLOT regimen over ECF. So that's a new standard of care in gastric cancer for perioperative chemotherapy. For the esophageal and GE junction tumors, I would advocate for combined chemoradiation. And there are ongoing randomized trials comparing the approaches, but outside of a study, that would be my paradigm for treatment. Still a lot to be desired with the outcomes with those therapies. We still have survivals only in the 40% range, and the majority of patients are still going to have recurrences. I think exploiting genomic analysis has not been a clear roadmap for new drug development, but to me the future in improving outcomes in systemic therapy is going to be looking at either immunotherapy drugs or targeted agents as part of adjuvant treatment to really suppress recurrent disease, and that's going to be an area of active investigation.